I'm now going to be talking about bedwetting, otherwise known as nocturnal enuresis, which basically means involuntary wetting of the bed at night time. Now, enuresis or bedwetting has two classifications. It can be primary or secondary. The most common by far is primary. So primary nocturnal enuresis is the involuntary passage of urine during sleep in a child over the age of 5 years who has never been dry by night before. Secondary nocturnal enuresis usually indicates a medical or psychological concern, and this is the involuntary passage of urine during sleep in a child who previously was dry at night. So I'm going to be talking mainly about primary nocturnal enuresis. In other words, children who've never been dry at night before. So what are the possible causes of primary nocturnal enuresis? There are a couple of theories as to why this happens. The most common is that it is a developmental delay, a delay in the maturing of the bladder-brain axis and the communication between the brain and the bladder at night. And this is a delay which just resolves on its own in time. A second contributor to nocturnal enuresis is children who sleep incredibly deeply. So those who just sleep through the signals going from the brain to tell the bladder, you're pretty full now, you need to get up and go to the toilet. Another contributing factor is if children have a small or irritable bladder. So if the bladder fills up quickly, it will need to be voided more regularly. But often those kids also have signs of daytime bladder irritability. For example, they need to go to the toilet more often than other children, or run to the toilet and have an accident before they get there. And lastly, a contributing factor is that some children produce excess urine at night. And this may be because of an underproduction of a hormone called DDAVP, which is responsible for reabsorbing water from the kidneys and bladder. A further risk factor for nocturnal enuresis is a family history. Very often this condition runs in families, or we will hear that dad or uncle or mom had the same problem as a little child. Drinking excessive amounts of caffeine, chocolate, hot chocolate, tea or coffee will aggravate the situation because it has a diuretic effect. And stresses in a child's life, such as admission to a hospital, separation from a parent, new child in the family, may contribute also to enuresis, usually secondary enuresis. Any child with enuresis also needs to be examined for an underlying neurological problem, such as cerebral palsy or spina bifida. Those kids will be much more prone to having bedwetting and a delayed control of the brain-bladder axis. So those are some of the contributors towards primary and secondary enuresis. So how many children actually do have enuresis? Well, at the age of 4.5, 30% of children still bedwet, and that's not yet considered pathological. At the age of 6, when most children are dry, about 10% of children still have bedwetting or enuresis, and the vast majority of these kids will just slowly get better over time. But of course there comes a stage and an age in which it's no longer socially acceptable to be bedwetting, and then we need to take some actions to investigate and treat the child. Let's talk about what to do when a child has enuresis. So the first thing to do is to visit your healthcare practitioner, because a couple of basic conditions need to be ruled out. The child will need a full examination to make sure that their innervation, the nerves that innervate the bladder, are working. There are no signs of a neurological problem. Also to make sure there are no signs of diabetes or indeed of a bladder infection, all of which could cause involuntary release of urine at night. Another big factor that needs to be examined for is constipation. So chronic constipation can certainly aggravate enuresis because the full rectum pushes onto the bladder, making it more easy to release and relieve the child of urine. How do we manage nocturnal enuresis. The first thing to say is that you need to determine whether it's primary, so the child's never been dry before, or secondary. The secondary causes the children who have been dry in the past, you need to try and find the underlying reason for their regression in their urine habits. Often it's stress, it might be something physical, might be severe constipation, and all of those things need to be dealt with. In primary enuresis, primary nocturnal enuresis, there are a couple of basic factors that need to be practiced in order to try and address this issue. The first is to make sure that the child is drinking adequately during the day. This is so that they're not suddenly thirsty at night time, because obviously drinking a whole lot of fluid before bedtime will aggravate the enuresis. So following that, we normally say children with enuresis should have no fluids at least an hour before bedtime. Just before the child goes to bed, they should be encouraged to go to the toilet and empty their bladders. It should even be encouraged to double micturate. In other words, go to the toilet after the bath and just before bedtime go again and try and get rid of any residual urine in the bladder. Some parents practice the art of lifting or a planned awakening of the child just before the parent goes to bed at 10 or 11 at night, taking the child to the toilet, letting them have a wee, and then taking them back to the bed. Although this has short-term success, it does not influence their long-term chances of becoming dry. So generally, this process of lifting is no longer practiced. If the child happens to wake up in the night, it is then a good idea to say, come, let's quickly go to the toilet and empty your bladder, and take the child then, but don't purposefully wake the child just to lift them. If there are dry nights, a positive reward system should be tried, and the child should really be praised and encouraged when they have a dry night. If the general measures haven't led to success within a few months, so restricting fluids, lots of daytime fluids, double micturition at night, encouraging the child to go to the toilet if they wake up at night, if that hasn't been enough to encourage dry nights, then certain additional steps may need to be taken. The best first-line treatment for nocturnal enuresis is something called the enuresis alarm or bedwetting alarm. This is an alarm that your pediatrician can arrange for you, and it is a little pad that goes into the child's pajamas or panties or undies, and it is sensitive to any fluid. So as soon as the pad gets wet, it sets off an alarm. And this creates the awareness in the child that they wake up when their bladder is full. So halfway through micturating, they'll be woken up by the alarm, and they are then encouraged to continue the micturition in the toilet. And this resets the brain-bladder axis, and over time trains the child to recognize a full bladder and wake up from it rather than sleep through it. So the enuresis alarm is our first line treatment for children with nocturnal enuresis. It is generally not used before the age of 6 years, because up to 6 years of age, the child has such a good chance of automatically outgrowing the enuresis, and it is not appropriate to treat them before then. A second line treatment is a medication called Desmopressin or DDAVP, and this is a medication that helps the body to reabsorb water from the kidneys and the bladder so that not as much urine goes into the bladder. And this should be offered to children generally over the age of 7, especially if the alarm is inappropriate or the family does not choose to use the alarm, or if rapid control is needed. In other words, the child may have a school camp where it's totally inappropriate to bedwet. So this medication is not as effective as the alarm, but may be used under certain circumstances. Generally, they are given a dose of the Desmopressin about an hour before bedtime, and it can be used up to 6 months in a row. Periodically, it is good practice to withdraw the medication for a few days to see whether dry nights have already been achieved, and then to reinstitute it if the child is still bedwetting. But generally, Desmopressin can be used for 6 months or so. A slightly older fashioned treatment, which is not often used but is still an option, is a medication called Imipramine. Now, Imipramine belongs to a group of medications called the tricyclic antidepressants. It's an old-fashioned drug with some side effects. It's sedating. It can cause cardiac side effects. So it's only reserved for very resistant cases, but certainly can help for nocturnal enuresis in children of 6 years or over. Once again, despite all the above actions, parents should be aware that accidents will occur. So children with previous bedwetting may have a couple of relapses and some accidents in between. The most important thing here is not to scold the child. They are not doing it on purpose, and not to create negative connotations with the training process. The best approach is to praise children for any positive steps. So dry nights should be praised. They should even be praised if they have a wet night, but then they go up and go to the toilet, or indeed encouraged to get up, help change the sheets before going back to sleep. So every little interim step should be praised to encourage the child to go forward with a positive attitude. Enuresis is common. It's distressing to the family, but it is something that is usually overcome within a few months and sometimes years.